All right, we are recording. For those that are just joining us for the first time, thank you for logging in and joining us this evening. Sorry about last week. We were a little busy with a lot of traumas and starting the new year off in the residency programs. Tonight we have a special lecturer on for the first time. Aaron Rubenstein, he's a PGY 5. He's going into hand. He's going to be doing his fellowship next year in Allegheny in Pittsburgh. So he's usually a very entertaining lecturer. So I'm excited for this.
Thank you for having me. Yeah, we'll be talking today about distal radius. But before we do, I think we're going to review last week or 2 weeks ago's topic of oncology, which is riveting. Joseph.
All right, guys, so let's jump right to questions. These things may look familiar for some of you. So 14-year-old male with right foot swelling. We talked about some of the appearance, radiographic appearance of tumors. One of the things we talked about was the zone of transition and what this means. Put my answer here.
How long do we give everyone?
Like 30 seconds.
Okay.
Yeah, it tells me how many people voted, so I usually wait till the majority have.
Jeremy's a big math guy.
Jeremy plays the numbers, man.
All right, there we go.
All right, so I just click it forward now?
Awesome.
Well done.
So like we talked about last week or 2 weeks ago, we talked about the zone of transition and what this means for an aggressive versus a non-aggressive appearing lesion. And so you can see here that there's a narrow zone of transition, perhaps even a small rim of sclerosis around this lesion. So that indicates that it's likely something that's been slow growing, and it is that you have the lesion doing something to the bone, and the bone is doing something to the lesion, starting to wall it up with bone formation. So again, this is something that is non-aggressive in appearance.
Then to the next question.
All right, you got a 15-year-old female with arm swelling. Take a look at the X-ray. We talked about some of the different things that we talked about for radiographic appearance of bone lesions. See what you think.
Solid work on the spelling from Jeremy.
Yeah, I just realized that and buried it down deep, and you just told everybody.
Yeah.
Yeah, bro. You never heard of permeative?
That's the one you do want, right? You want permeative? You don't want permeative?
It's extra special.
Excellent.
Alrighty, let's share the results. You got some explaining to do.
All right, so probably got some people who are new to this. So we talked about a geographic bone destruction. This is when we talked about something where you have kind of a distinct shape or section of bony destruction that you can recognize and kind of place your eye on. But if you look at this X-ray here on the right-hand side, there are scattered lesions throughout the almost entirety of the humerus. You can see areas of lucency, areas of sclerosis, all these bony changes, and it's kind of throughout the whole bone. And so like we talked about on the last slide, when you have something where there's a distinct, if you look at the calcaneus X-ray that we just had, you could see not only that there was a lesion with a well-defined narrow zone of transition, but also that you had a distinct shape. If you look at this, you don't really see any zone of transition. You see, scattered lesions throughout, and so we call this a permeative appearance rather than a geographic where you could see that circle in the calc, right? So the other thing we're looking at the cortices. And so we know that periosteum is on the outside of the cortex of bone. And so usually on a normal X-ray, you can see kind of clearly defined, nice white cortical lines on the edges of the bone. Here you don't see that. If you look proximally, you see kind of erosion and without that clear line. And then you can see more distally, you could see aggressive bone, bone reaction and growth. You can even call that a Codman's triangle. So, these are all hallmarks. If you look at the last lesion versus this lesion, the last lesion is a very non-aggressive appearing lesion. This is an extremely aggressive appearance. So I wanted you guys to be able to kind of see two ends of the spectrum, have a good understanding of the difference between the two. Hopefully that makes sense. All right, so you have a 63-year-old female with weight loss and pain when ambulating at the left hip. We talked about differential diagnoses briefly, but what I want you guys to get into the habit of is having an understanding of looking at the age of the patient and not just the x-ray. So let's see if you guys remember some of the major things we talked about. Remember, this is an old patient. Older.
Yeah. This question's all about age. Alrighty. Killing it.
Excellent. So we talked about Mets, myeloma, lymphoma. Those should always be at the top of your differential on a patient of this age. Just to review briefly of the other diagnoses, we talked about osteosarcoma and Ewing sarcoma. These are primary malignant bone tumors typically found in patients younger than 20, but oftentimes between around 8 to 14, but it ranges. But it's certainly a younger person's disease, similar to ABC, aneurysm bone cyst. When you look at this lesion, this is not an aggressive appearing lesion like osteosarcoma or Ewing sarcoma. They would also not typically be found in this region. A more common x-ray that you're going to see on your boards or on test questions, you're going to have a distal femur or proximal tibia lesion, either in the metaphysis for osteosarcoma or more in the diaphysis for Ewing sarcoma. Then when you think about fibrosarcoma and undifferentiated pleomorphic sarcoma, now these are soft tissue sarcomas, and so you wouldn't see just a pure bone lesion like this. You might see a soft tissue shadow with a calcification that's abutting the bone. But again, an isolated bony lesion, older patient, think Mets, myeloma, lymphoma.
And then more.
All right, flip it on its head. We just kind of talked a little bit about some things here. Look at the appearance of the lesion. Think about if it looks aggressive, if there is periosteal reaction, or if you can see a well-defined narrow zone of transition here, and then kind of piece that together. And again, consider the age. This is the opposite, 11-year-old patient.
And the poll, please.
Rubes is over there.
All right, so, I figured, so you guys are thinking about the age, obviously, so that's great. Osteosarcoma and Ewing sarcoma are definitely young, disease of young people. But again, if you take a look at kind of this, you can see these well-defined lines at the cortices here. You don't see a lot of expansion outside the cortex. You don't see a lot of periosteal reaction, aggressive appearance of the lesion. This is a relatively non-aggressive appearing lesion. So, something like a aneurysmal bone cyst or unicameral bone cyst is a more likely diagnosis. We already talked about osteosarcoma and Ewing's, and the other things we talked about, chondrosarcoma is a disease of older patients, certainly older than 11, usually definitely older than 20 most typically, and anywhere from 30, 40, 50. And you talk about giant cell tumor similarly, would not be very common at all in a patient younger than 20. So just some of those things to sort through when you think about age.
Last but not least.
We were just talking about this today. I'm curious to see the opinions. Keep my opinion to myself until the end. Judy got me thinking about this, Jeremy.
Yeah.
He's so pumped.
Of course. Wow.
I should have put the Toyota Tacoma for Joe.
Yeah. All right. There we go.
Yes.
The OJ Ford Bronco.
Absolutely.
White.
So excited. It's coming out, 2021.
For when you are
I
making.
can't wait.
So Rune is voting for first generation Forerunner.
That's it. That's my move. All right.
And also for you guys that are just joining us, feel free to type in questions in the chat as we go along, and we can get to them either at that time or later on. And welcome, Joe Galloway.
All right. Thank you, Joe. That was really great explanation. And for the less than 5% of you going into tumor, you will benefit so much. On to something we see every day, distal radius fracture. All right. So just briefly, we'll fly through this. What we want to get out of today's talk is a little bit of background, some important anatomy, how you're going to see these guys down in the emergency room, the trauma bay, a little bit about the imaging, classification, and why it's probably not that important. Initial management, what you want to do downstairs, non-operative management, what you want to do in the office, and operative management is all we care about, clearly what you want to do in the OR. A lot of this talk was helped with some of our hand attendings at NJMS, Dr. Vospikian and Ahmed, so good thanks to them. All right, so just get the mind flowing. This is a case of mine from probably 2.5 weeks ago, and it's a 28-year-old guy who fell off a ladder, but then fell down 20 stairs off of that ladder. So these are his plain films that he presented with. And that's a wrist. It's not his wrist. It's some old lady's wrist from another consult, but it is representative of what you could possibly see with this. So moving on to the background. A little bit about the epidemiology of these and why they're important, okay? They represent about 15% of all the fractures in the extremity, and they're the most common upper extremity fracture. So this is relevant for you guys. You will see it no matter what if you are an orthopedist, even if you work in the ER. Age range. There are really two ways that you can get these fractures. There's the lower energy fractures, and those are the people who fall off of something, and then there are the higher energy fractures, and these are your trauma bay type players or guys who just do stupid things for fun. So the low energy fractures are more common, and just like most fractures, you see two peak ranges. The first would be younger people, and these are maybe children who fall off of beds or monkey bars, and then older people who just fall and they're old. Old people break things. Higher energy fractures is almost always young adults and predominantly males because testosterone. Getting in a little bit to anatomy, I thought I would divide this by sort of a more macro view, looking first at the bone, and then a more micro view looking at the actual composition of the bone and how it happens. So when you look at the distal radius, it is a lot more complicated than people give it credit for. If you look at the joint surface, which in orthopedics tends to be one of the most important aspect of a bone, you can see two independent articular surfaces with the carpus and one with the ulna. The ones with the carpus are the scaphoid facet, and I don't know if you can see my pointer, but I'm pointing at this. It is a more transversely oriented depression. It is at the radial side of the distal radius. We don't normally say medial and lateral, more like radial and ulnar. And it articulates with, obviously, the scaphoid. It's about 2/3 of the width. And then the next is the lunate facet. And the lunate facet's here, here, here. And what this is a more vertically oriented or A to P oriented oval depression. And that's at the medial 1/3 of the distal radius. And obviously that will articulate with the lunate. The next thing is the scaphoid notch. And the scaphoid notch is about 90 degrees, so it's perpendicular to the lunate facet. And this is where the ulnar head articulates. A key concept, just something to remember, is that if you see fractures on the more medial aspect of the distal radius involving the joint, they tend to involve the DRUJ, or the area where the radius and the ulna articulate. And this has a lot of implications on motion, and that's what we care about in orthopedics. The ulnar head is the complement to the sigmoid notch, and you can see the ulnar head sitting here in the sigmoid notch and here, and it's covered by cartilage. The ulnar styloid is located here. It is a posterior-based structure, and it is an area for many ligaments, something called the TFCC, which is a big hand-weenie topic. We can get into it later. And then if you look at the ligaments, there are quite a few of them. So to avoid going into too much detail, you can see there are many volar and dorsal ligamentous complexes, and these function as stabilizers of the carpus or the hand on the wrist. Extensor tendons are another thing to be concerned about because they're in very close proximity to the dorsal aspect of the distal radius and ulna. So things we can do with these potentially is injure them with our screws if our hardware goes too far, or rupture in specific types of fractures. This is the microanatomy, and this is just a little bit more of a breakdown of what we're looking at. So if you want to understand the bone, you should understand what's inside of it. The thickest part here is the subchondral plate, and the subchondral plate is basically what holds up the carpus. And beneath the subchondral plate are these bone plates here that function effectively as I-beams. And that transmits the load down from the carpus into the distal radius. We have these trabecular struts, which are basically the equivalent of these vertical oriented beams on a bridge, and that's transmitting the load to these arches. And the arches bring the loads out to the cortices, which bears the majority of the weight. So if you look at this, the analogy is kind of like having a bridge. Getting a little bit into the presentation, most commonly these people fall, like we said, is the low energy mechanism, and they usually fall into an outstretched hand. So this mechanism is a hyperextension mechanism, and when you have a hyperextension mechanism, what happens is the volar, or the anterior colloquial cortex, undergoes a tension type failure, and as it fails in tension, the dorsal cortex fails in compression, and you get a dorsal displacement. A lot of people will land on their palm, extend the wrist. I'll show you a couple of pictures of this in a second. This lady on the bottom looks like she probably did that to herself, and what you see is this very characteristic deformity. I always learned of it as a dinner fork deformity. It looks like it's called a silver fork deformity here, but it's kind of this serpentine S-type pattern to the wrist in deformity. Another thing to always look at is you got to look at the skin, and you got to look at the neurovascular status. So open fractures obviously portend a different type of management with antibiotics and operative debridement. And so you have to check this out and be very thorough. Also, if you can imagine, the median nerve runs from the forearm into the hand through the carpal tunnel. And you can see that a displacement here would certainly put this median nerve on stretch. So a lot of people will develop paresthesias in their first 3 fingers consistent with some kind of a stretching of the median nerve. Vascular exam, you can imagine that obviously the vessels run in that course as well. So make sure that the fingers are perfused, make sure there's a good pulse, etc. And then we tend to get a very focused in on certain things, but make sure that you're looking at the global picture. The patient can certainly have injuries up through the elbow as the force transmits from the arm or from the hands through the arm. The ulnar styloid is another thing that we look at, and that portends some ligamentous issues with the TFCC. And then finally, sometimes higher energy mechanisms can cause carpal dislocations, and that's your perilunate insufficiencies or instabilities. These are some neat little slides that I took from a conference I was at in Berlin, and it's just basically how variations of the position of the hand and variations of the forces cause different types of fractures. So characteristically, this is kind of your extra-articular distal radius fracture, but you can see how changing the position can cause shear fractures, either dorsally or volarly, or very high energy can basically just split the articular surface. Kind of simply stated, this is the effect of the hand being either in ulnar deviation or radial deviation, and then as you transmit a load through the carpus, it splits at areas of weakness, usually the plate between the 2 facets, and then fractures propagate out from that in a characteristic type fashion. So there was a good study by this guy Bain, and he basically looked at, this is an axial cut of a wrist basically, of the distal radius. You can see the dorsal and the palmar, and they put the ligaments on here and found that those areas are somewhat protective for fracture lines. And so by mapping tons of CTs, they found best fit patterns existed right between areas of ligamentous attachment, and it divides it into a radial styloid piece, a volar ulnar piece, a dorsal ulnar piece. So looking a little bit about imaging, this is a really important thing to become comfortable with. Whenever we see these patients, we should get x-rays and we should get a full 3-view wrist series. That's your AP, your oblique, usually pronated like 30 or 45 degrees, and then your lateral view. If you look at these two images on the left side here, you'll see that the joint lines, which are really the most important thing, are not really clearly delineated. You kind of don't see a nice joint space, which you can see here, and you can see here on the lateral. And the way that we attain those views are by kind of tilting the wrist. So in the AP view, it's about a 10-degree tilt, and in the lateral, it's about a 20-degree radial type deviation. And that will let you look down the joint line a little bit easier and be able to articulate, evaluate the articular surface. CTs are a good adjunct, particularly for looking at intra-articular extension, intra-articular step-off, evaluating the extent of comminution or any defects in the metaphysis. And MRIs have a very limited role in distal radius, but mainly if you're just looking at things like the TFCC. So I think a really good exercise to do is to try and identify fragments on plain films. So I gave you guys here an AP and a lateral view of a comminuted intra-articular distal radius, and we should see if we can break down what each one of these are. So looking first at the radial styloid, this one's probably the easiest. It's this big chunky piece coming off the side, and if you look at it on the lateral, it's this flared wide part at the end. Looking next though at the dorsal medial corner requires us to basically evaluate a little bit more than just the AP, because if you look on the lateral, you can see that the dorsal cortex compared to the volar cortex is more proximal. So if you want to point that out on the AP, you got to see it down here. And that's what we're pointing at. If you apply that now to the same logic to the volar cortex, you'll see that this is more distal, about midway through the lunate, and you can pick that one up right over here. And then finally, the shaft fragment, that's probably the easiest. It's the big wonkin' thing over there. This is just a good characteristic of what CTs can provide you with. This is articular depression. This is articular step off. And this is that same axial cut showing you that fractures do in fact follow the pattern of a styloid, a dorsal, and as a volar, and a dorsal ulnar corners. So classifications, this can be overwhelming. You can see the AO, the Fernandez, the Malone, the Gartland, the 3-column, and I think that one in the corner is the Frickman or something. But regardless, it's a waste of time. They don't get you anywhere. Most people never say, I've got a Malone 3. They just describe the fracture, and that's really helpful. Some people like to use eponyms. It's usually a relic of the old times, but these old fogies got their names on a fracture pattern, so you might as well know them. Colles and Smith fractures are both extra articular. Colles has a dorsal displacement, while Smith has a volar displacement. A Barton's fracture is a shear, either on the volar aspect or the dorsal aspect. A die punch fracture is a joint depression. You can see that right there. And a chauffeur's fracture is this very large radial styloid piece, and you got to beware because that could be the first stage of a perilunate problem, which is another hand weenie thing, not for this lecture. Initial management. So this is the fun stuff that you guys as medical students might be able to get to do down in the emergency department with your resident, and this is how to make the x-ray look better, how to reduce the fracture and put it back. There are multiple ways of doing this, but usually they involve some degree of a longitudinal traction, and then they usually require, if it's a standard kind of dorsally displaced fracture, some posterior to anterior force. So this first image shows the dorsal displacement, and then it shows that by hanging the fingers in finger traps and by putting a counterweight, usually down over a bent elbow, you can attain length. And then by just pushing your finger from P to A, you can reduce that fragment. If the fracture edges are sort of completely displaced and you have to deal with a full displacement, you might have to unlock those fragments. And the way that you do that is by hyperextending and then applying a distraction, and then translating again from posterior to anterior. And you can see that in motion down on the bottom. Next comes immobilization. There are a bunch of ways to immobilize. If you are doing this on an adult, you usually want to apply some type of a sugar tong splint. A sugar tong splint immobilizes primarily in the sagittal plane. It's a good way to combat that fracture from falling back off dorsal. This volar resting splint is probably not a great idea. It would just let the fracture fall right back where it came from. And if it's a kid, you can do some cool as shit cast and make them like Captain Avenger or Ninja Turtles. So then we need to know how well we did. We need to know why we're reducing these fractures. And this largely comes down to the radiographic parameters that portend better prognoses with non-operative management. So the first is radial height, and that's this B over here. It's a line from the DRUJ, basically, right in the middle, up to the radial styloid, and the distance as measured between the two. It's most commonly 11 millimeters. There's obviously a little bit of variation. And what is acceptable? Post-reduction, 5 millimeters shortened. And how do you know that? Well, you can compare the other side. Radial inclination, seen down here, is a similar line across at the DRUJ, and then a line that connects up to the radial styloid, and it's an angle, and that's 22 degrees. And then finally, volar tilt is a line perpendicular to the shaft axis on a lateral, and then the angle that that makes with the distal radius articular surface. And that's normally 11, and acceptable for post-reduction is usually less than 15 degrees dorsal. So 11, 22, 11, kind of easier numbers to remember if you need a way to do it. Another thing we look at, obviously, is intra-articular step-off or gapping, less than 2 millimeters. Kind of hard to do without a CT, but you can certainly get a approximation. So then we get to the fun stuff, right? To cut or not to cut, that is the question. And we look at our operative indications. So outside of the high trauma things with maybe open fractures or polytrauma patients, which I'm sure Jeremy and Joe want to hear about, but we're not going to talk about. We talk about just your standard low energies, and that indications for that would be either inability to attain an adequate reduction or failure to maintain an adequate reduction. So what basically clues you in that you're not going to be able to maintain a reduction? What lets you know that this is an unstable fracture or an unstable fracture? And that would be LaFontaine's criteria, which was a study done to evaluate what characteristics of fractures mean they're more likely to fall. So dorsal angulation greater than 20 degrees, comminution, either dorsally about 50% of that cortex or any volar comminution, initial displacement of 1 centimeter, initial shortening of about 5 millimeters, associated ulnar fractures, or old people with bad bone. Now, these aren't things that you guys necessarily need to just know, right? I look it up more or less before I get one of these consults every time, but I think that if you kind of understand what characteristics make a fracture unstable, you'll know which ones need to be fixed.
Yeah, I think it just makes sense if you just go back to that. Initial displacement is going to mean that it's usually a little bit higher of energy that cause it to displace that much. And then most of these want to displace dorsally. So if you have really bad angulation there or comminution in that area, when you try to put a mold on that spot, it's just going to be too comminuted to hold any reduction there. And then obviously older, worse bone is going to be a little bit harder to maintain a reduction.
Yeah, they're fairly intuitive, but they are certainly useful. So non-operative management, the boring stuff, none of us want to do this, but this is how you would manage a stable or non-displaced distal radius fracture in the outpatient setting. And what you would tend to do is basically immobilize them after the reduction, follow them up at about 1 week and get an x-ray to make sure they have not displaced, then follow them weekly for about 3 weeks. And you can transition them at that point either into a short arm cast if you had them in a splint, or some custom-made thermoplast splint. You want them to be moving their fingers, their elbows, and their shoulder to avoid getting stiff. You want to keep them elevated and control the swelling with cool therapy. And then in about 6 weeks, maybe a little bit less if you're comfortable that the fracture is not going to move, you can take them out of that cast and you can start letting them range more. And if they're not doing well and they're very stiff, you should consider occupational therapy. With these fractures, you do have some wiggle room. If you see it displacing and you catch it early, good job. You can either re-reduce it or you could indicate them for surgery. And then one very testable concept is that somebody who's treated non-operatively comes back to your office, later. And what tends to happen is that they have the inability to extend their thumb or one of their tendons are out by the question stem. And the question is always, what is that? And what do you do about it? And it is usually a tendon rupture. And the answer is usually you have to reconstruct the tendon, not necessarily primarily repair it. All right, the fun stuff. All right, so this is just an overview of the different types of operative management. We'll get into each one of them very briefly. Close reduction and pinning is something they used to do a lot back in the day, but a little bit less so now. You use them usually for the more length stable type fractures, the ones that are isolated styloids or not a lot of comminution. And there are two main types of pinning. There's intrafocal and extrafocal. What you're looking at on the screen right now is extrafocal pinning. This is pinning outside of the fracture site. It just crosses and holds the alignment. And then intrafocal pinning is this technique, which is basically you put a pin in the fracture site and then you make a correction using the pin and then you drive the pin across. It's also known as Kapandji pinning. The downsides to this is you still got to cast them, right? You still got to leave the pins in. They can break the pins. The pins are external things that come out of the skin. They can get infected. And they'll probably need some rehab at some point. External fixation, right? Reasons we use the tried and true X-Fix would be if someone has a polytrauma and you just need to stabilize them fairly quickly. If the skin or soft tissues in the area of the wrist are compromised and you don't want to put incisions or hardware there. You would use these often if they're very displaced or comminuted and you just need to distract the joint surface to get them to heal. One thing that is a prerequisite is that you're pulling through the soft tissues whenever you're manipulating something with an X-Fix. So you need to have intact ligaments. And you can use these also to neutralize any pin fixation that you put in. The benefits is that they're very much less invasive. You're making these all through very small incisions with just like a spreading with a hemostat. It is very stable in the wrist and that it's pretty straightforward and still adjustable. You can actually make adjustments to it. But the pitfalls are that by making these small incisions and putting trocars and drills and pins into the bone, you can injure the structures in that area. And most commonly, that's the sensory branch of the radial nerve, which is usually injured about at the wrist. And that can obviously cause a lot of numbness over the dorsum of the hand. Another thing is that by locking them up, you can make them very stiff. And by having pins that connect from the outside to the inside, you can have infections. This is a nice solution to the X-Fix, which is basically what we call an internal fixator. So none of these screws are really directly going into the fracture site. They're spanning the fracture site. They're anchoring into, in this case, the third metacarpal and the proximal radial shaft here, or just the radial shaft. But it is holding that fracture out to length without pins that poke out of the skin. And it is working biomechanically more advantageous because it is the distance between the plate and the quote unquote pins and screws in this case is very small. The pitfalls to this is that you're making 3 small incisions usually and sliding this guy down. So when you do that, there are a ton of tendons that run into the hand. And sometimes if you're not careful and you don't release them, you can trap those tendons and that is an issue. So now kind of the more fun surgery stuff. This is open reduction and internal fixation, which is looking at the fracture site sort of directly and manipulating it. The benefits of this is that you can restore this anatomically if done the right way, that you can stably fix it in place without pins, that you can move your patients faster, and so they can get back to their activities. There are a bunch of ways you can do it, but one of them is the volar plate, and they're usually locking. They don't have to be locking. So when you go volar, you can look at some of the fracture lines, and this plate can really be applied in 2 different modes. The first is a buttress, and the second is basically fixed angle or sort of a rafting type feature. So a buttress fracture, right, is for anything that's usually a partial articular injury, right, that is liable to displace via shear forces. So this fragment here, volarly, wants to displace down. And if you think about where you would put your thumb or put something to stop it, it's exactly where the plate is. And this screw is trapping it so it can't displace. That's a shear fracture. What it does need to have is a competent cortex here because it needs to compress the plate to the bone, but it is a biomechanically very advantageous construct. The second is a fixed angle, and a fixed angle relies on locking screws, and I'll show you a little bit more in a second, but basically these screws, and I don't know if you've had a lecture yet on locking screws or not, but they thread into the plate. So they actually don't really need to contact the bone surface that much. They thread directly into the plate, and by doing that, they form a fixed angle. So that holds whatever fragment that's in that position. It's a fixed position. So you actually don't even need to have a dorsal cortex because it's functioning almost like a peg holding up a certain area. And I'll show you some pictures to help kind of conceptualize this. But with these fixed angle devices, you have to be very comfortable that your radiographs are good because you're not really seeing the articular surface. You're just imagining it's in the right place based off of your x-rays. So here are some fixed angle plates. This is a whole assortment of what they can look like. They come in nice shiny colors. Jeremy's favorite is purple. They have locking screws. So you see the threads here, and the screw is threading into these holes. And then they are designed to literally hold up the subchondral bone at the angle you're putting it in. So you see here, it's rafting more or less this articular surface up in the position. And these screws don't even need to be out dorsally. In fact, if they are out dorsally, they can irritate the tendons and cause a lot of problems. So we intentionally leave them short. Couple other adjuncts are dorsal plates or fragment specific plates. These are two different things. I just put them on the same slide. A dorsal plate obviously goes on the dorsum of the distal radius. You can see here, the indications for those would be something that's like a dorsal shear where you want to put that buttress up against it. Also, when you are fixing these, if you need to look directly at the joint, the easiest way to do this is dorsally, where you don't have to violate the volar ligaments, which can destabilize the wrist. So any intra-articular stuff that needs to be directly reduced can be done dorsally. And then if you also have some kind of a carpus injury that you need to see dorsally as well, you can combine this. The problem with this is that you're putting a plate on a bone that has tendons that run directly over it without any protection, and you can get tendon ruptures. Sometimes people get hardware issues. They get some tenosynovitis, and that needs to have the plate removed after they heal. And then lastly, they have a shortcoming. They won't stop anything that's falling off volarly. They're only dorsally positioned. Fragment specific looks really damn cool, but it's probably more work than it's worth. So this is basically using really small plates and wires and screws to hold individual fragments in place. And you can get the x-ray to look perfect, but at what cost? You can really strip all the soft tissues off and cause hardware issues in the future. But then again, it does look pretty cool, so who knows? So let's get back to our case. We're just about to wrap up here. This is what the junior resident down in the trauma bay was able to do for our gentleman. These are his post reductions. You can see he's in a sugar tongue splint. Looks like he tried to apply some degree of a mold here to hold everything in place. So the question is, where do we go from here? We either have non-operative, operative, or no, I was not aware there'd be questions. Poll on us, Jeremy?
Sorry, I was muted. We don't have a poll for this one.
Well, that is tragic. All right. Well, how about this? Option D, I didn't give you all the information. We got a CAT scan, which is what you can do. And if you look here, some of the things the CAT scan provided us with was a degree of displacement volarly, but more importantly, dorsal comminution. We can see an associated ulnar styloid fracture. We can see a dorsal ulnar piece, and looking at the axials, we have a dorsal ulnar corner, we have a volar ulnar, and we have a comminuted styloid here. So if we go back to our friend LaFontaine, we'll see that we are totaling 3 points at minimum. You could probably drum up another one from somewhere. So that's enough for me to do surgery, and we did.
Hey Rubes, why did you guys get a CAT scan on that case?
I think when we looked at this initially, I can fly all the way back to the index procedure, but A, based on mechanism, but B, this dorsal comminution was very apparent on the injury film. And so we were concerned that the energy basically required a high energy to produce this fracture. And we wanted to look at the dorsal articular surface to verify that. All right, so that's our fracture. After we fixed it, you can critique it and say how we did, but we used a volar locking plate, right? These screws are all fixed angle. These are cortical screws, which go through 2 cortices, and you can see here that the articular surface is being held up by my screws, and they're not protruding out the back. So, review question time. Let's get to the first one here. As this is a picture from the presentation, what radiographic parameter is being shown here, and what is the acceptable limit for this? I don't know why it says ankle, but disregard that.
Oh, sorry, that's a wrist.
Hey, I got it right on the poll question.
All right, let's see what we got.
Give me a couple more seconds.
Oh, word.
People are thinking, Rubenson.
No, I'm sorry, I'm rushing you.
Alrighty.
Good job to the majority here. So I would say this is half test-taking strategy. What is being shown is an angle, and therefore it cannot be a millimeter as the answer. But what we're showing you here is volar tilt. And again, volar tilt is a perpendicular to the shaft and a line that goes across the articular surface. And you can see here that it is normally needs to be less than 15 degrees dorsal.
Also, with volar tilt, sometimes you compare to the contralateral side, and if it's within 20 degrees of the contralateral side, that can be acceptable as well.
Yeah, for sure. All right, so now we're thinking biomechanics here. What is the biomechanically most advantageous way to fix this fracture? So everyone knows, I just orient you, this is a lateral view, right? This would be the volar aspect of the distal radius. This is the lunate, which is attached by the carpal ligaments to the distal radius. So how would you fix this? What would you do? You can just amputate and forget the problem if you want.
Always an option.
Always an option.
Alrighty.
Good job with the volar buttress plate. So if you think about this fracture here, where would you want to put your finger to hold it in place? And this is now like an AP-ish type view of that prior fracture. And you see the guy's finger is holding up. He is buttressing that fracture, and that is a volar buttress plate. That's exactly what that plate does. All right, last question. I showed this to one of my mentors. He said, it's an okay question, so if you don't like it, I'm sorry. But this is the advanced question. Which picture most closely represents the mechanism of a fixed angle volar locking plate? So 3 different types of fracture fixation being shown here. The first one intramedullary, second one some screws, the third one this plate down by the ankle. which one of these is functioning similar to how a volar locking plate fixed angle is functioning?
Galloway's looking very closely at this.
Galloway's right. It's actually a very not good question. I'm sure he's doing some advanced Boolean mathematics for that.
Alrighty.
All right. This one we do not have a majority on. It is the second answer. So the first is an intramedullary nail. This is basically just a load-bearing device which is more or less going to transmit the force down it. The second is the fixation of a tibial plateau fracture. And what these screws are doing is it's actually holding up or rafting the articular surface. I don't really know if they did raft the surface that well on this or if this is just compressing, but that's what I was trying to show. And then the last is actually a buttress plate flipped upside down or an anti-glide plate. And what that's doing is resisting the displacement of this medial malleolus fragment. So if you look here, you can see that even if you removed this piece of dorsal cortex, the plate would hold the fracture at the fixed angle that you're putting it in at. So that is the answer. Maybe not the best question, but trying to show you guys a concept. That's all I got, guys.
I think the difficulty with that is just that we use volar locked plates for several of those biomechanical principles. Sometimes we use them to resist shear forces. Sometimes we put them in a buttress mode and then complement that with fixed angle, some subchondral fixation. So I think that's probably where some of the confusion came from, as you can see how it could be used for honestly 2 or 3.
Certainly not 1. Don't do 1.
Hey Rubenstein, can you go back a couple slides to your, I think it was just your post-op images? And looking at that lateral, can you explain why you're going to put the plate more distal? Why it's in that position?
Yeah, so there are a few reasons why you don't want to put the plate more distal. There's a guy named Sung, and he looked at classifications of basically radiographic plate placement and risks for things like tendon ruptures or issues. So if you put this plate more distal, you're violating this line that we see called the watershed line. And that's getting into the volar carpal ligaments. And you can't go any further than that. Additionally, the way that this fixed angle plate is, those screws are more or less going to go in this orientation. If I put it more distal, they'd probably violate the articular surface as well.
Okay. Hey, Aaron, I just noticed that you just kind of, sorry, a different Aaron in the chat asked something similar about that prominent volar plating past the watershed area. Do you have any other questions similar to that, or? While he's typing that out, as you guys can also see in the on the left side on these APs, in the more proximal portion of the plate, there's an oblong hole, and you can use that where you can place a screw in that and then shift your plates proximal or distally so you get a good alignment of your plate there.
Any other questions?
There was also Aaron in the chat is asking also, is there anything you're looking at intraoperatively while you're fixing this?
Yeah. So for this one, my joint surface wasn't terrible, as you can see from that pre-op CT, but I was afraid that it would displace because the dorsal cortex was so incompetent with all this comminution over here. So I wanted to just make sure that I had some screws that were restoring my tilt appropriately, and fixing it at just the appropriate angle. And I wanted to make sure that I wasn't putting any of those screws in the articular surface by doing that. Another complication to this case is if you don't have a very competent dorsal cortex, it's very tough to gauge how long your screws are. Your depth gauge doesn't really give you the greatest measurement because there's not much to hook. There's just a lot of comminution back there. And because of that, you have to be very concerned about not leaving screws too long, as those could cause, tendon irritation, possible rupture.
So I think what I would say is some of the other stuff that you're looking at is similar to a lot of other plating, making sure that your implant is centered on the bone so that you would get good fixation. A lot of the things that we look at to determine whether our screws are okay and whether our plate is in a adequate position is based on the adequacy of the images that we get. So if you were to look at the center image there, and you look at an oblique, some of those screws look like they're in the joint. But a principle of projectional radiography, which is just turning a three-dimensional image object into a two-dimensional image, is that something can look like it is approaching and going into or across the border of a concave structure, or a convex structure, sorry, and it looks like it enters or exits that structure. But if you got a slightly different view, you would find that it never actually crossed that boundary. And it's all based on the fact that you're just stacking a three-dimensional object on top of itself. So that if my hand's here, if I position my right hand more proximal than my left hand, it's contained within the left hand. But if you were to look at it from this angle, it looks like my right hand projects more distally than my left. So it's all based on knowing what images give us the best view. And then if you're concerned, something that we do is we can put the x-ray or fluoroscopy machine on live for a temporary period and just irradiate all of ourselves and range the wrist or the joint through, take it through a range of motion. And if the screw goes into the joint, you'll catch it on one glimpse. You'll find that it enters the joint. And all you need is just one image that shows the screw is in the joint, and that proves that it's there, that it's in the joint.
Something Dave, right?
Yeah, it's getting those tilt views that Rubenstein was talking about earlier. And that has to do with what Joe was saying. It's just the orientation of the joint line. And so there's dorsal tilt, so we want to tilt in that direction that many degrees. It's a little bit different for each patient. And then the same thing on the lateral. There's that radial height and angle. So you want to tilt that same degrees for each individual patient.
Yep. Anything else, guys?
But what approach do you usually do for your distal radiuses? I know.
Are you talking to me? I'm talking to you.
Anybody?
I think that the volar FCR approach for applying a volar locking plate is probably the most utilitarian. That approach is basically centered over your FCR tendon, which you can feel in your wrist. It is slightly ulnar to your radial pulse. And you can actually follow that up as a tendon for a decent amount. And so you want to center over that and right about to the level of the wrist crease. You have to think whenever you cross a crease, a transverse crease, if you put a longitudinal thing on it, it can contract. Scars can contract post-op. So you would want to angle it. Sometimes people angle towards the carpal tunnel. Sometimes people angle this way. And then you go down through the skin. You'll see the FCR tendon. You want to incise over the tendon. You mobilize that tendon ulnarly. There's a posterior sheath. You open that up. Deep to that, you'll see the FPL as it comes to the thumb. and you move that out of the way. And then beneath that is the pronator quadratus. It is kind of a rectangular based muscle over the distal aspect of the radius. You want to elevate that in an L-shaped flap, and then that will bring you immediately down onto your distal radius, and you can expose your fracture that way. You want to make sure you respect that watershed line. Don't go too distal, or you'll start violating your volar carpal ligaments, and you have to bring those. You'd have to repair those, and sometimes with a suture anchor if you mess them up.
Nice.
You also have the radial artery there, so be careful. Excess dissection radially will hurt you.
Oh, and then another trick intraoperatively, once you reduce your fracture, a lot of people will put a pin from the radiostyloid retrograde into the shaft, and that helps hold your fracture in place while you apply your plate and do some other different things intraoperatively. And then one other thing I just wanted to mention earlier, you were talking about paresthesias in the hand from that stretching the median nerve. A lot of the times they improve when you do your reduction and get it back into better alignment because you release that stretch on the median nerve. However, if they continue to have symptoms or those symptoms get worse, then you want immediately take them to the operating room for a carpal tunnel release. And one of our attendings says if, anytime they have any type of symptoms, they buy themselves a carpal tunnel release just to be on the safe side.
Yeah, that's certainly an interesting consideration. We have some who are much more aggressive at our hospital, and then some who don't really get too aggressive with it. Unfortunately, for a hand guy like me, I want to do as many carpal tunnels as possible, but there's not much literature showing that doing the carpal tunnel at the time of the distal radius is actually going to help with those symptoms. It's kind of a catch-22.
Yeah. And a lot of the times people will just extend their incision past the carpal wrist crease to get to the carpal tunnel.
Oof. Strong work by other Aaron asking if we give everyone vitamin C post-op. So the reason for that was born out of a few studies that looked at, is it CPRS or CRPS, complex regional pain, CRPS, and that people after these surgeries sometimes got CRPS, which is like a devastating condition. Your hand becomes just incredibly sensitive and is like an absolute torture. And there were some studies that showed that giving vitamin C was beneficial. The more recent stuff has actually shown that was not the case, or that doesn't really pan out across studies. So we don't give everyone vitamin C post-op. I think a lot of places are moving away from that.
Joe Galloway, you have anything to add?
No, I think it's a great talk.
Yeah, I agree. Thanks, Rubenstein, for doing it.
Thank you, guys.
Thanks, guys, again for joining. We're discussing between us, but I think we might be stretching out the lectures and doing it every other week, just because we're ramping up back to our normal busy schedules. But we hope to get you guys as many lectures as we can going forward. We plan on over the next couple of weeks doing some more hand lectures and some more sports related lectures. And if you guys have any requests, feel free to email us on that thread that Joe Ippolito is sending out, or you can DM us on Instagram. Again, the Instagram account's NJMS.orthopaedics.